Imagine two people born the same day in the same city, same potential. One grows up in a neighborhood with stable housing, good schools, grocery stores, safe parks, and clinics nearby. The other grows up where rent is unstable, food is expensive, transportation is unreliable, the air is worse, and violence feels closer. Now, fast forward 20 years. One is more likely to have asthma, high blood pressure, diabetes, depression, and to even die earlier. Not because they made worse choices, but because the playing field was tilted from the start. Today, we're talking about income inequity and mainly the widening gap between people who have resources and people who don't, and how that gap becomes health disparities. Hello, everybody, and welcome back to the Mindful Matters podcast. I'm your host, Shavain Bhutani. And in this episode, we're going to be talking about what income inequity really means. And I'm going to go into the pathways of income to health, how money really becomes biology. Then we're going to take a look at how this looks in real life. And then I'm going to give a piece of my own experience actually scribing in the ED in St. Louis. Then lastly, we're going to talk about what works, practical solutions, and my favorite part, what you can do at home. So let's dive in. And just a note before we start, I know in previous podcast episodes, I've said that 94% of podcasts fail before episode 7 and how this will not be one of them. And this is episode 7. And I just want to assure you that we're going to be hitting the ground running. Coming forward, you're going to be seeing a lot more frequent episodes. So stay tuned. But let's dive into today's episode. What does income inequity actually mean? Well, income inequity isn't just that some people earn more. That's always been true. It's really when it becomes a health issue is when the gap is so wide that it determines who can reliably access the basics. That's stable housing, safe environments, good schools, healthy food, transportation, and medical care. So the core idea here is that health isn't only made in hospitals. Health is made where people live, learn, work, and play. So, how does income really become health? There's 5 concrete pathways I kind of want to break down. So, the first one is when income is tight, housing is often unstable. People could be moving frequently, there could be overcrowding, living with molds or pests, even poor ventilation, or even other unsafe conditions. See, you see these conditions and you think, okay, that's just housing problems, instability, but that's asthma, that's sleep disruption, that's chronic stress. It's hard to manage your blood pressure when you're managing eviction notices. Another pathway is food environment, access, and affordability. See, just eat healthier sounds simple until you realize healthy foods can be more expensive, harder to reach, even harder to store if you're stretched thin or living unstably. For example, I go to college right now in St. Louis, and I go to the supermarket, and I see organic bananas for $2 and I see regular bananas for $1. Now, as a college student with money tight, I'll buy the $1 bananas. I don't need to buy the $2 ones. But that's me personally. A lot of people don't even have that choice. They don't have the choice to eat healthier if they wanted to. And that's what's leading to seeing these higher rates of obesity, diabetes, and cardiovascular disease. And it's not because of moral failure, but because the options are constrained. Third pathway I want to go into is transportation and time. If you don't have reliable transportation, a routine appointment becomes a full day project. If you're hourly wage, taking time off can mean losing income or even risking your job. So a lot of people will delay things until they are urgent, and then preventative care drops. Conditions worsen and the ER use rises. Another big factor is healthcare access because insurance is not the whole story. Even with insurance, affordability matters. Co-pays, deductibles, medication costs, and availability is a big factor as well. We're seeing fewer clinics and longer waits in under-resourced areas. And probably my most key pathway I want to go into and a key takeaway is how chronic stress is a big factor to these biological problems. See, it's really the bridge from social to medical. When stress is constant, you see financial insecurity, unsafe neighborhoods, discrimination. The body stays in that heightened state, higher cortisol, inflammation, blood pressure. And over time, it really does contribute to heart disease, anxiety, depression, and pregnancy complications. See, income inequity doesn't just change lifestyle, it changes physiology. So I kind of want to go into what this will look like in on the ground. So that would be people rationing insulin or skipping blood pressure meds because rent is due. It could even mean missed follow-ups because the clinic is too far or the next appointment is months out. It can even be parents choosing between groceries and therapy visits. We're also even seeing more mental health crises where stress is high and access to care is limited. And there's a consistent pattern. When resources are scarce, prevention becomes a luxury, and we end up treating advanced diseases that didn't have to get that far. And I saw a lot of this when I was scribing in the ED. And I want to make this personal for a second because for me, this isn't just a policy language. When I was scribing in the emergency department in St. Louis at SSM Health Cardinal Glennon Children's Hospital, I kept seeing the same pattern. Families weren't coming to the ER because they wanted to use the ER for everything. They were coming because in practice, the ER is the one door that was reliably open. I'd be seeing kids coming in sicker than they needed to be, not because the parents didn't care, but the early steps were blocked. Maybe they couldn't get a clinic appointment quickly. Maybe transportation was a problem. Or maybe the parents couldn't miss work without losing wages or risking their job. There are so many other factors that were involved. And in pediatrics, you see how fast small problems become big ones when care is delayed. An asthma flare that spirals, dehydration that becomes dangerous, and infections that might have been handled earlier if access was easier. See, this is what income inequity looks like in clinical life. It's not just less money, it's less margin for error. One missed paycheck can mean missed meds, missed follow up, and now suddenly you're in the ED. Now, zooming out, insurance is one of the clearest ways this shows up. I'm going to go into some data. It'll be linked down in the description below. All the data I get it's from the Census Bureau ACS site. But nationally, the uninsurance rate was 8.2% in 2024, up from 7.9% in 2023. In Missouri, one of the census data analysts showed 7.5% of Missourians were actually uninsured in 2023. And for kids specifically, about 5.2% of Missouri children were under 19 were uninsured in 2023. But the real takeaway from all this data is that uninsurance and underinsurance is not evenly distributed. See, in the city of St. Louis, white residents were least likely to be uninsured at about 7%, followed by black residents at 14%, with Hispanic residents reported the highest at 21.7%. So when people ask why didn't they come sooner or why didn't they just go to their primary care, this is the answer. Because access is not just a phone number. It's time, transportation, money, flexibility, and the ability to miss work without consequences. And income inequity squeezes every one of those. And this really brings us to a myth I want to challenge, that the idea that health is simply about personal choices, as if everyone is choosing from the same menu. See, choices matter, but choices happen inside constraints. For example, if your neighborhood has no safe place to walk, exercise more lands differently. If your schedule changes weekly, meal prep lands differently. If you're uninsured or your plan doesn't cover the clinic you can reach, be proactive lands differently. So, a better question than why didn't they choose better is what choices were realistically available. So, kind of backing out now, I kind of want to go into what actually helps, the solutions that really move the needle. And the truth is, there is no single fix, but there are proven directions. And by first, we can start by strengthening the basics. That's house, food, and income support. Housing stability reduces health crises downstream, and food support drastically reduces chronic disease risk. And income support reduces toxic stress and improves stability. And that all that means fewer emergencies and more prevention. Another big thing I want to stress is making healthcare easier to use, extending clinic hours to evenings and weekends, telehealth when appropriate. I actually have an example here. My dermatologist does telehealth only in California. So when I want to go to St. Louis for college, I can't telehealth. And then getting my medication is not as easy because I have to wait a couple months until I'm finally back in town, and then that can really mess up the cycle of things or the timing with prescriptions. And so it's a really big factor to be able to make this accessible for everyone. And telehealth, I think, is important. Community health workers to help families navigate systems. I think we need that. And another big thing, co-located services. That's like primary care, behavioral health, and social support, all under the same roof. We really got to target the barriers, not the motivation. That's transportation support. We got to simplify medication access and really have realistic care plans that match real life. Lastly, we have to invest upstream because health policy is housing policy, it's education policy, labor policy, it's environmental policy, because those are the systems that are shaping risk long before someone becomes a patient. So, my favorite segment, what can you do at home? Well, if you're a student or clinician, ask respectfully what makes it hard to take care of your health right now. Build plans that are realistic, not ideal. Really know your local resources and refer what follow through. And advocate inside your institution for flexibility and access. Change is not going to happen in a day, that's for sure, but we can definitely start now. If you're not in healthcare, support programs and policies that stabilize housing, food access, and wages. Volunteer with organizations doing direct support. Learn your city's health map, where the gaps are, and talk about it. You don't have to be in healthcare to make a difference. Anyone can make a difference here. Anyone can make a change. We just got to be proactive and get out and do it. Because the truth is, health disparities are not inevitable. They're built, and what's built can be rebuilt. So I really hope you enjoyed today's episode of Mindful Matters. If this topic hit home, share it with someone who still thinks health is only about personal responsibility. Thank you for listening. Take care of yourself and take care of each other.